Good morning, ladies and gentlemen. Thank you for the organizer inviting me to share with you on the experience of managing thalassemias. And my talk will be concentrating on the screening, chelation, and also transplant. And the reason why we talk about this topic in this region, because we are having a high prevalence of thalassemia in South China, and beta thalassemia carrier rate in Hong Kong is about 3%. And so the best way to prevent this or to manage this disease is by preventing the new cases. So prenatal diagnosis is important, and there are now established ways of doing prenatal diagnosis based on fetal DNA analysis of the chorionic villi or amniotic fluid DNA. It can be done by DNA sequencing, restriction enzyme polymerase chain reaction, or amplification refractory mutation system. Or more recently, the Oxford group reporting using the pyro sequencing, which should be simpler and also less expensive. However, all these are invasive. So is there any non-invasive way to make the prenatal diagnosis of hemoglobinopathies? And Dr. Dennis Lowe and his group did a lot of work on using the fetal DNA in the maternal plasma. The fetal DNA actually present in the plasma of pregnant ladies, and that can be used for non-invasive prenatal diagnosis of quite a number of diseases, for example, for Down syndrome. And the early work of this non-invasive maternal plasma method is focused on detection of the paternally inherited fetal mutations in the maternal plasma. But recently, they developed the model of using a digital relative mutation dosage approach that determines if the dosage of a mutant and the wild-type alleles of a disease-causing gene are balanced or unbalanced in the maternal plasma. So it is feasible. It's feasible for the non-invasive prenatal diagnosis of several hemoglobinopathies, including beta thalassemia or hemoglobin E disease. But it is still in the very early stage, but we hope that in the future it may be widely applied as a method of prenatal diagnosis. So the second part of my discussion is on the chelation. Now, everybody knows that with repeated blood transfusion, it will lead to iron overload. And the organ which has the most serious complications of iron overload is the cardiomyopathy. Up till now, cardiomyopathy is still the #1 cause of death in thalassemia major patients. And of course, we hope that these kind of Iron Man can be prevented by our iron chelation. We don't want our very nice, very happy child to become this Iron Man when they grow up. And so how do we assess this iron in the body? It has been, for over 2 decades, people have been using serum ferritin as a measure of the cardiac iron overload in the body. And Lancelot Lefebvre in the mid-90s already demonstrated that for serial monitoring of the serum ferritin, if they with less than 1/3 of the measurements over 2,500 nanogram per mil, actually these group of patients have a rather good cardiac disease-free survival over 10-20 years, whereas those who have higher serum ferritin level, more frequent high levels, then they have a marked drop in the survival. However, everybody knows that serum ferritin is a non-specific reactant. So people would like to look at something more directly on the body iron by looking at the liver iron. The liver iron, and the people can obtain the liver biopsy and then measure the liver iron content. And it has been shown that for the hepatic iron, if there is over 15 milligram per gram dry weight of the liver iron content, there is that is the threshold for developing cardiac disease and early death. It also applied in other types of iron overload conditions. However, liver biopsy, everybody knows that it is invasive and may also with risk, and also patients are always refused for the second biopsy if they had one done some years ago. So is there any way to measure the body iron using non-invasive method? The MRI of the liver, either by using IL-2 or T2 star, has been found to be having a good correlation with the liver iron content, and it has been shown to have a very good correlation, so that that actually has been validated and has been approved to be by the FDA and in the EU as well. So in conditions like not only in thalassemia but hereditary hemochromatosis, this iron measurement can also be applied. And this is just an example showing that one of our patients with very high hepatic iron of 20 milligram, and actually the MRI showing that a very intense signal. So that is for the liver. But as I said earlier, cardiomyopathy is still the #1 cause of death. So we should look at the heart closely. Of course, we cannot put a needle into the heart to get a cardiac muscle biopsy to measure the cardiac iron content. That is something we have never been done. But now we have also the non-invasive method by using the MRI, which by using the T2 star measurement. And for anybody who have T2 star value of more than 20 milliseconds, and it has been shown that they are all having the normal LV ejection fraction, whereas those who have a T2 star less than 20, they start to show abnormality in the LV ejection fraction. And this is the diagram showing that this patient in the LV wall, actually there is not much iron, it looks quite normal, whereas in a patient with a severe iron overload in the heart, actually the LV wall was very dark. And this has been shown that with the lower the T2 star, the higher the chance that these patients will have abnormal LV ejection fraction. And this, for some unknown reason, we don't understand why the correlation of liver iron and cardiac iron may not be very close in each individual. For example, in this patient, the cardiac iron is not very high. You can see that it's not very dark. But whereas in the liver, you can see it's a very high, having a very dark signal. It signifies severe liver iron overload. On the contrary, in these patients, the liver was relatively spared from the iron overload, but the heart is having heavy iron overload, and these patients are at risk of dying from cardiomyopathy or arrhythmia. And so once we have a better tool to assess the iron in the body, including especially in the heart, then we would like to look at whether we can prevent these causes of death. And over the years, and the number of deaths has been still high among these beta thalassemia major patients, even though they are provided with chelation. And mainly it's still due to iron overload. The reason is because of the chelation compliance. And that deferoxamine has been in the market for more than 3 decades, and this is the conventional treatment. Unfortunately, this is injectable form requiring to be infused over 8 to 12 hours, at least 5 to 6 days per week. So it is extremely difficult treatment to get a good compliance. So oral iron chelator is now getting into the market for deferriprone, or the trade name Feriprox has been used for more than 10 years. And it has a good compliance, but the side effect is having neutropenia or granulocytosis in 1 to 3% of patients. The more recently developed iron chelator is the desferoxavox, or the trade name called XJ, and is given once by mouth, is also having a much improvement in the compliance. And as I said, that if patients are having these difficult treatment, the compliance will be poor. Once their compliance is poor, then you can see that the survival will drop rapidly after age of 10. In the first 10 years of life, they do not die from the heart failure because the amount of iron accumulated is still not to the dangerous level. But after age of 10, especially in adolescents are usually not very compliant with treatment. So they start to have a fall of the survival due to the cardiac death. So people have been trying to use find out what is the more effective way of iron chelation. One of the more commonly accepted mode of treatment is a combination therapy by both the injectable form, that's desferoxamine and deferriprone. The advantages of using these combined treatment, including that because we are using two different chelators, they are having chelation of two different iron pools, and also there is increasing efficacy. And if we can achieve a good iron overload, we can reduce dose in some of these, one of these iron chelators, so the toxicity may also be decreased. And also having better compliance and quality of life will improve, and also preventing the NTBI accumulation. Now, this is the data that nearly 10 years ago from Italy, and they did a study comparing people on deferriprone, the oral chelator, and the injectable deferoxamine, the survival and cardiac disease over a period of 6 years. And they have been treated for at least 4 years with either treatment. And during the follow-up, and none of the 54 patients treated with deferriprone died. But 4 of the 75 patients treated with deferoxamine died during the study period, mainly all are due to the cardiac disease. Deferriprone actually has a better cardiac protective effect because of the smaller molecular size that can get into the myocyte better. And another study also from Italy, more recently they look at a larger cohort of patients. They are either treated with monotherapy of deferoxamine or deferriprone or combination. And these are the number of patients treated by either deferoxamine alone or deferriprone alone or combination. And among these deferoxamine treated alone patients, 8 out of 124 patients developed arrhythmia. But the number of patients who have been treated with combination treatment or deferriprone had a much lower chance of developing arrhythmia. But more important is about the death. Among the 12 deaths, 7 were due to cardiac disease, and 6 of these cardiac death patients are actually receiving deferoxamine prior to death. So the deferriprone has been shown to have a good iron cardiac protection. So how about the most new oral chelator, desferoxavox? And actually we also joined in this study, and we completed the study about a year ago. And this has been shown that with in a 3-year study, and it shows that the T2 star overall increased from 12 to 17. And also, if those who are in the mild to moderate cardiac iron overload group, that is between 10 to 20 milliseconds, and started with a baseline of 12, and then majority improved to returning back to the normal MRI-T2 star value. So these patients are now free from the cardiac death. And for those more severely iron overload patients, and they also showed an improvement, but at a slower rate of improvement as compared to those less severely iron overload patients. So we believe that in the longer term, probably they will have even further removal of the cardiac iron and should be remaining cardiac disease free. And so how about in our local situation with the start of the MRI assessment and also more wide application of the combination therapy, and Dr. Au, our session chair, also reported recently that we had a marked decrease in the cardiac death in the recent years. So finally, going to the last part of the discussion is about the transplantation. Transplantation for thalassemia is still the only curative method. And it has been started using transplantation since in the early 80s for beta thalassemia major. And the results has been shown that with HLA matched sibling donors, we can offer about 80 to 87% probability of cure according to the risk groups. And however, these are mainly for the children population. For adult patients, usually they are having more advanced disease with more iron overload, more organ impairment. So the transplant result is still inferior due to the advanced stage of the disease. And more recently, other than sibling donors with the high-resolution tissue typing techniques, we can also allow our allogeneic stem cell transplant from unrelated donors. And the results actually is now quite comparable to sibling donors. I will show you some data later on. And the advances in transplantation biology actually made it possible whether haploidentical transplant may be considered. But this is still in the very early phase of the development. And another area of interest is about unrelated donor transplant using cord blood. And the result is also encouraging. Also, one of the problems of transplant thalassemia major patient is the graft rejection, either primary graft rejection or secondary graft rejection. And there are also some data showing that even though if they reject the graft, they may be transplanted for the second time, and even with the same donor, still with a high chance of disease-free survival. Another area about these thalassemic patients after transplant, what we call the ex-thalassemics, we also follow up these patients in long term, and then they are now transfusion-free, but the treatment-related complications they acquired before the transplant, for example, the endocrinopathies like diabetes mellitus or the hypothyroidism, these are still irreversible, so they still require this treatment after the transplant lifelong. Now, the largest series of unrelated cord blood transplant for beta thalassemia major actually comes from Taiwan, Chang'an University. Over a 6-year period, Dr. Jiang reported 35 patients with 40 transplants. That means 5 patients had the second transplant performed, and most of these are having 1 to 2 antigen mismatch. 6 out of 6 match is actually uncommon in cord blood transplant. And with these non-manipulated grafts without ex vivo expansion or T-cell depletion, they identified the high cell dose numbers with leukated cells of 7.8 and also CD34 of 4 times 10 to the power 5 per kg, quite a reasonable good number of stem cell dose. And with such a higher cell dose, and then they can achieve a thalassemia-free survival after the first transplant, 88%. But there's a problem of graft rejection. So after first transplant, the thalassemia-free survival is only around 74%. And there's also transplant-related mortality of around 11%. And but chronic GvHD is not really a big problem in the unrelated cord blood transplant. Finally, 35 patients with 30 patients alive and then becoming transfusion independent with a good landscape performance score. And so the result is quite encouraging. And how about unrelated bone marrow transplant? The Italian group reported one of the large series of unrelated transplant, 68 patients, median 15 years old. And also graft failure is a problem, 13%, with 20 patients died from transplant-related diseases. causes. And GvHD is also a problem. And the overall survival is about 80%, with a disease-free survival of only 66%. So that is from the Italian group. How about from China? And as you know, is having a single child policy, so it's quite impossible to get HLA identical siblings. And health insurance system is also quite expensive to have a lifelong treatment. So unrelated bone marrow transplant is quite attractive. So in Nanfang Hospital, they have performed one of the largest series of unrelated PBSC transplant in a single institute with 61 patients, conditionally cyclophosphamide, busulfan, ATG, and fludarabine. And there were 5 transplant-related deaths. But they have a very low rejection rate of only 1.6%. So the overall survival and event-free survival is around 90%, which is really remarkable. But we still need to have a longer follow-up for the chronic GvHD after the PBSC transplant. So in summary, prevention is still the best way. So we hope that in future we can use the non-invasive maternal plasma for the prenatal diagnosis. And we allow having more accurate cardiac iron assessment. So together with the newer oral chelator, improve the compliance, also reduce complication and also mortality. So we are seeing patients now in the age of 40 and 50s. And also with better HLA matching, we can now perform safer unrelated donor transplant. And also with improving results in younger children. Okay, thank you for your attention.